Dr. Nitesh Gahlot is here with us to discuss a very interesting case on an injury on the medial side of the knee. Let's see what he has to say.
Good morning, everyone. So I am presenting a case, a rather interesting case and very unusual kind of an injury. The patient had a medial-sided knee pain. So that is a very common finding what we have in when the patient presents to us with the knee pain. Some background of the patient: 26-year-old male, complains of pain in the right side of the knee since past 6 months. He had an injury during the fall while playing football. And since past 6 months, he has been having some amount of pain when walking, while running, constant pain, has been under treatment by various doctors, physiotherapy and all he has already taken. On examination, there was tenderness on the medial joint line. The valgus stress test was negative, but it was painful on the medial joint line when I was doing the valgus stress test. Whereas anterior posterior draw test, they all were negative, and the Macquarie test was also negative. So these are the MRI. I would like everyone to have a good look on the MRI images. Okay, so these are the other images. These are the sessile T1 and T2 images. And we'll go to the ARS questions, please.
ARS, please.
So what diagnosis comes to your mind with this background, with these images? Okay, so 1, 2, and 4. Okay. So can we move on to the presentation? Yeah. So the radiographic evaluation, actually there was no obvious tear of the MCL. Definitely there was a sprain of the medial ligament, but continuity was maintained. What I could see is that the meniscus was lifted off from the tibia, so on this side. And he was specifically having middle joint line tenderness and no middle femoral or the distal tibial MCL attachment. So basically, I thought that this is probably the cause, because these are MRI images and this is a very unusual kind of isolated injury that is being reported in the literature. So I went in, this was the meniscotibial ligament injury on the medial side. So that is part of the deep MCL actually. The deep MCL has two parts, one is the meniscofemoral and the meniscotibial part. So this is actually the separation of the meniscotibial part of the ligament. So what should be the further management of such type of an injury? Okay. Anyone would like to speak in favor of the first option? Leave it as such. The patient has been having continuous complaints since past 6 months. Anyone would like to?
Let's take the opinion of our esteemed panel. Anyone in the favor of just leaving it alone?
Complete physiotherapy he has taken. Bracing was not given, and he has taken all strengthening exercises. He had taken adequate rest also for first 3 months. He was not doing. Then he started graduate physiotherapy. Then with me also he had taken 1 month of physiotherapy, and before that also. But he was continuously having that pain while walking. He complained of medial sided pain, No locking, nothing else. Only medial sided joint line pain. He always complained that while walking, I am having the pain on the inside of the knee.
And you mentioned that he plays football as well, isn't it?
Yeah, that injury was
as a result of football.
When he injured.
Recreational football or at an elite level?
No, it's a recreational.
Recreational.
So can we go back to the slides, please?
Was there any proper rehabilitation followed for this patient?
Yes, sir. He mentioned he underwent 1 month of supervised rehab.
Considering there is no nothing been found in the MRI, what sort of rehab protocol did you follow for him?
Yeah, so that's a more important question. Rather than saying he went under rehab with me for 1 month and with somebody else for 3 months, what kind of exercises did you put him on?
Actually, he had already taken rest before coming to me. So that resting part after the acute injury was already over. So he came to me that in mid-chronic phase at around 6 months. So that was time, he was started on exercises, basically isometric, non-isometric exercises of hamstring and quadriceps. He was asked not to climb stairs, not to do too much weight bearing, no playing, no exertion. That was I did not put him completely to rest or bed rest kind of a thing that we do typically for the MCLs, because he didn't have any medial-sided laxity per se.
No trial of offloading braces.
Pardon?
Medial offloader braces.
No, I did not do it, but initially he had done that. He was on complete bed rest after the initial injury 6 months back, but that was under other physicians.
How was the VMO when you examined him? How was the VMO of this patient when he came to you?
A bit wasted, yes. A bit wasted as compared to the opposite side.
Did you work in it, and did you do any put in any specific rehab for the BMO and all?
So that was the basic quadriceps strengthening and the hamstring
So
strengthening.
is there
exercises.
anything specific in your mind, Sarthak? Are you thinking of neuromuscular stimulation? What do you have in your mind?
So basically, like this patient with no clinical finding, what happened with the absence of proper rehab, they go on slight mild stiffness of the medial aspect, sir, with proper VMO strength weakening. So just 1 month of rehab won't be doing if you put him on more on excessive single leg proprioceptions rehab protocols. They will come back out of it, like, because the MRI shows nothing.
No,
So-
I agree with your point actually. But the VMO strengthening and quadriceps strengthening, they work more when you have significant weakness, and that weakness is causing the pain, and the patient has anteroposterior laxity.
So I think point is well taken. All of us are trying to harp that an exhaustive rehab. Yeah, a quick point, please, so that you can show the video.
Regarding the pain, when was he getting the pain? At rest or loading?
On loading, yeah, on walking.
When you were examining also, was he getting pain?
Yes, at that time also.
Valgus, okay.
Yes.
Yeah.
So I made a diagnosis of medial meniscotibial ligament injury, but that was a radiology-based diagnosis. I had to go inside and confirm it. So my plan was to, if I found something, I will fix it. If there is a meniscal extrusion kind of thing, that is a different issue I will address. So this was the initial examination. So I was able to lift off the meniscus on the tibia completely.
So Nitesh, if I can interrupt you here and ask you, how often do you do pie crusting of the MCL for difficult, hard to reach posterior horn of the meniscus? And how different is this from the pie crusting that you usually do?
I rarely do pie casting, but when we are doing the pie casting, we are doing above the meniscus.
Oh, so you're doing it at the femoral end?
Yeah.
Okay. Anybody who does pie crusting at the tibial end? I mean, I generally do it at the tibial end. So the tibial pie crusters, do you find, Ritanjali, you raised your hand, do you find anything different to this picture when you do it from the tibial end?
Grossly looks the same to
It
me.
looks the same. Okay.
But the medial side was otherwise fine. There was no meniscal tear, there was nothing else on the medial aspect. Just had a check on the lateral aspect also, and that was also fine. I went in, there was nothing on lateral aspect, just for the checking, and the posterolateral compartment was also fine. But there was nothing actually abnormal, no meniscal tear, no meniscal root tears per se, which cause the extrusion commonly. And on deeper probing, I was actually able to put my scope below the meniscus. It was moving at a sleeve. I was actually able to put my scope below the meniscus. It was so freely moving, and the capsule layer was moving up and down with that. So I decided that probably this was cause of the pain, because the pain was exactly at this side on the outside. So what I decided was to fix it with an anchor and do what we call as a medialization of the meniscus.
Can I ask a question?
Yes.
If you look at the video, is it not more on the posteromedial aspect rather than medially? Why not call it inferior ramp rather than calling it a meniscotibial?
I agree, sir. The deep MCL is actually a slightly bit posterior than the midline, actually, the deep MCL part, and is actually not in the anterior on the midline part. So probably it's this is anatomically described actually in the study, that is although a bit posterior from the midline.
Yeah, so it bit posterior is actually posteromedial, right?
Yeah.
And it can be a ramp tear where what you are actually looking, which is actually also described and commonly seen in our practice. Because till now I was feeling that there is no tear, but as you are able to put your scope under the meniscus, so now I'm feeling yes, there is a tear.
Yeah.
And it's more on the posteromedial side.
So the ramp lesion, in my understanding, is probably the separation of the capsule and the meniscus, meniscocapsular separation at that level. Here in this, the meniscus was completely attached to the capsule all the way around.
There are different types of ramp. There are
Yeah.
meniscocapsular tear, meniscotibial tear, and both the tears. So there are 3 types. So it is an inferior type variety of
I
ramp
agree.
tear.
Probably a variant of that.
Nitesh, just a question. You know, your main symptom was pain. And when you have pain and you have this kind of a scenario after 3 months, I'd actually see synovitis below this region. When there's no synovitis, I mean, I'm sure you got a great result at the end of it. I'd be a little skeptical fixing something like this. It just...
I agree. I also went in this case with that mindset. Okay. So I eventually decided to fix it. What I did was pass a spinal needle, make a way for the anchor through that from the medial side, and the anchors were fixed. Now my scope is below the meniscus right now in that part. The anchor was fixed. the spinal, after passing the anchor, needle was passed at the posterior-medial part where the sir said the deep MCL is there. This passed to the anteromedial portal. That anchor was pulled in, one thread was pulled inside, then passed through that, and then they were tied on the lateral aspect of the.
Nitesh, this anchor is not easy to insert. I mean, all of us who have done centralization anchors know that this is difficult. So, what are your tips? I mean, to me, it looks nearly as difficult as putting in a hinge wire for an osteotomy. So, what are your tips on putting this anchor?
I agree, sir. It is very difficult to get that exact position at that inclination.
You're almost skirting against the condyle while you're putting the anchor, isn't it? So, do you think a curved sleeve, things like that would help you better put this anchor? All suture anchor probably more than a solid anchor. You think that has a place?
Yeah, probably a curved sleeve will help better.
Nitesh, I just have a question. What are we trying to achieve here? Are we trying to reduce extrusion, or are we trying to fix the meniscotibial part of the ligament? Because if we are trying to fix extrusion, then I would actually insert the anchor from front of the meniscus onto the the bone, and then take bites from the meniscocapsular junction. So I think extrusion vis-a-vis your MRI actually doesn't seem significant. The extrusion is more or less normal. It's more of a meniscotibial separation.
Very important question that you have asked. Thank you for asking. So I am not treating this as a meniscal extrusion. In the MRI, the meniscal extrusion has two grades that has been described: less than 3 millimeter and more than 3 millimeter. And that is when more than 3 meter you treat. On the MRI, there was no extrusion was there. So I am not treating an extrusion. I am treating the meniscotibial part of the injury, because it's still a part. Meniscal extrusion is mostly described in degenerative conditions. That is, extrude slowly at the hoop stresses that lead the meniscus out of the tibia. So I am treating the meniscotibial part here.
Just one point.
Yes, Santosh.
My clinical diagnosis in such a case would be first a medial tibial stress syndrome, where you need to check the BMI and vitamin D to be checked first. Conservative management would be my way.
Okay, so he's rooting for conservative. Bhushan?
So when you said you're going to put an anchor, I was dreading to see an anchor going in the mid part of the tibia of central.
Just like what Vikram suggested, isn't it?
And wrecking the joint, but that's a good placement of anchor. My only question is, we are treating a meniscus which is separated from the tibia simply. Why not just use inside out sutures, maybe 3 or 4 sutures, and tie it down, so that you are also getting a compression of the meniscotibial ligament, and at the same time you are also putting the meniscus flush on the tibia. So every time we do a meniscal repair, when you put the sutures on top, the meniscus lifts up, and when you put a couple of sutures down, it comes down. So that might.
What do you want to tie it down with? If you want to tie it to the bone, so how are you planning to?
So whenever you are tying the sutures, so if that's the meniscus, your sutures are going from inside, coming out, and then second suture is going in the capsule. So essentially squeezing the meniscotibial ligament. So you are actually compressing the meniscotibial ligament.
We need something on the bone actually, because the completely capsule is separated from the tibia. So
do you think the capsule is completely separated?
With the capsule.
So that's, I think, another way. Bhushan's perspective is another way to do the same thing. I think for want of time, we would have to urge you to show the entire follow-up and discourage further questions. Very sorry about that.
So this is at 1 year. So there was no extrusion at that time. A bit of healing there. Some suture hypertensity is there as compared to this preoperative MRI. So I would say that has healed. The important thing is the patient was fine. With a weight bearing exercise at 1 year, there is absolutely no medial joint line, medial space collapse. And this is the patient at 1 year. He actually had resolution of symptoms only after 2 months of repairing. When I started weight bearing, I stopped him weight bearing for 2 months. But he recently came to me at 1 year, and he's pain free, absolutely pain free. So that was probably the cause of the pain. That was causing the pain. I had published 14 cases of this in OJSM. All were not isolated. A lot of them were associated with ACL and other injuries also. So basically, it's a kind of a thing that is easily missed. And I will important that Dr. Vikram has already. This is different from meniscal extrusion. The meniscal extrusion is extensively described in the literature, but those are mostly degenerative cases. And this is a traumatic one. So all the cases are reported were the traumatic cases actually. They were not the degenerative chronic cases where meniscal extrusion occurs in conjunction with osteoarthritis.